Welcome, everyone. Welcome this evening to an introduction to palliative care. Before I introduce our host, I want to make sure that everybody is aware that we are recording this webinar and that if you have any questions, please put them in the Q&A section at the bottom of your screen. There's also closed captioning should you choose to use that. Throughout the presentation, feel free to ask questions, but there will be time at the end. If there's something that either myself or Kara can answer, we will do so. But like I said, at the end, we will save room for questions. So now I'm going to introduce our host. Rachel Ehrenberg is a clinical social worker with the inpatient palliative medicine team at Sibley Hospital. After college, Rachel completed a joint master's degree program at the University of Michigan, receiving a master's in social work and a master's of public health. She spent her career aiming to find positions that would allow her to focus on integrating health, education, mental health, and medical care. Her current position, which she helped to build, has been the most rewarding and the closest to meeting that goal. Prior to employment at Sibley, Rachel worked as a programs manager at the American Lung Association of DC, as a school social worker at a local preschool, and a medical social worker at several hospitals. When not at work, Rachel enjoys crafting and spending time with her friends and family. Go ahead and take it away, Rachel.
Hello, everybody. I am Rachel Ehrenberg. Hopefully this will go smoothly. You'll have to bear with me. I have not used this kind of technology in a long time, and I can't see anyone. So we're just kind of flying blind together. But I'm here today to talk about palliative care, also known as you're referring me to what? I don't know what people have heard about palliative care, but often that is the first response providers get. When you think of palliative care, is there anything in particular that comes to mind? Might have to put it in the chat and Janie can let me know. Does it look like anyone's typing?
Not yet. We do have a Go Blue, Rachel.
Go Blue. Indeed. Okay. And the, Hopkins colors are also maize and blue. So we got that. Okay. I'll tell you, when I hear palliative care, well, when patients talk about hearing palliative care for the first time, often they will say things like, I'm not ready for that. I still have things I want to take care of. I'm still seeing my oncologist. And sometimes even the providers don't fully understand that there's a difference between palliative care and hospice. And so it just kind of leads to a lot of stress that probably doesn't need to be there. So hopefully tonight we'll kind of dispel some myths and let you know what it really is and if it can benefit you. All right, so instead of listening to me prattle on the entire time, I'm going to show you this little video, maybe.
I knew at some point in my disease process I was going to need additional support. I reached out to palliative care.
When he got that diagnosis, we knew that it would be really helpful to have their support through this process.
The focus was to manage symptoms, to find ways to allow Ginny to do the things that she wanted, to feel the way that she wanted.
The crux of a palliative care team is that it's a team-based approach to care, really aimed at treating the physical symptoms as well as emotional and spiritual symptoms of a serious illness.
Commonly, that is a physician, a nurse, a social worker, sometimes a pharmacist and a chaplain, and then these additional people that can extend the care.
There was this relief when someone would walk in the door and say, hey, my name is so-and-so and I'm with Palliative. Great.
That was just so comforting to know that that support was there.
Well, I think initially when people hear palliative, there's this natural response to think hospice, to think end.
The difference between hospice and palliative care is that hospice is there for you when treatment no longer makes sense or when treatment for your underlying disease isn't being offered to you anymore. Palliative care is there for you at the time of diagnosis as well as throughout your illness trajectory. That may be for years of care while your underlying disease is being treated.
Now, importantly, that does not need to be a terminal illness. We have many patients who are going through advanced treatments for curable cancers or curable leukemias. Integrating palliative care early on in the course of these illnesses provides for better outcomes for patients, both in terms of their physical symptom burden as well as their emotional symptoms.
Our first meeting with them was really just getting to know about Brian and I and about his cancer diagnosis and our family and kind of what our goals were for treatment.
I want to live my life versus being constantly focusing on my disease process.
One of our important roles in palliative care is to help be a sounding board for patients as they navigate through the healthcare system. Very often our patients and their loved ones tell us they are seeing specialists in all sorts of areas. They're getting lots of information. What we try to do is to funnel all of that information into some easily digestible bits, as well as allow patients to bounce off ideas about what's important for them.
I feel like the decision-making was easier because we had, again, that team of folks that was trained, skilled, were great listeners. So often what would happen in a decision time for us is we would express our feelings about it, express our thoughts.
We can then take what's important to patients back to the other clinicians and say, hey, let's put this all together into a plan of care that will meet this patient's goals, preferences, and values.
They've really advocated on our behalf within the complex system of Brian's treatment.
We've worked very hard to establish close relationships with our oncology colleagues, our cardiologists, our primary care clinicians.
We just want to be here for you as an added layer of support to help all of your other teams treat you well in this very holistic kind of approach.
Even though pain is a different division, they worked very closely with our palliative folks to monitor and to manage Ginny's pain.
When Brian had a pain crisis, we knew we could call palliative care and they could help us sort out where he should be seen, and we're able to address those issues and were a lot of support and reassurance to me emotionally.
They cared about our care. We built strong connections with them. They walked with us step by step by step.
When we talk to patients about the definition of palliative care, that it's a medical specialty aimed at helping their clinicians provide the best quality of care possible, that it provides relief of pain and non-pain symptoms and improvement of quality of life, and that it's there for their caregivers, over 95% of patients want that for themselves, want that for their family members.
I have felt that they've been just as supportive to me as a spouse as they are to Brian. This is certainly not something you go through alone, and so they've been that extra layer of support.
There was not one appointment, not one, where I left and hadn't been asked how I felt, what I needed, what they could do for me.
The whole team is really thinking about how many different ways can we impact and improve this patient's life in the midst of the illness.
I just believe that it is a powerful, powerful piece of what Mayo Clinic has to offer. And it is part of that world-class care.
Okay, I'm gonna try and escape out of this back to the PowerPoint. Okay, I think that worked. Substitute Mayo Clinic with Sibley, Johns Hopkins, of course. But I hope that that sort of snippet helped dispel some myths. You see people being treated both inpatient setting and outpatient by a multidisciplinary team who's really focused on quality of life. So what is palliative care really? It's a specialized form of care for people that have serious illness. And the focus is really on comfort, to palliate, to relieve suffering, to aid in comfort. So we do that in a number of ways. We focus first on any really distressing symptoms that somebody might be having. So somebody might be having pain or shortness of breath or nausea and vomiting. They might have anxiety or agitation. All of these are things that really affect someone's quality of life. So we want to address the physical symptoms foremost. We also want to look at people from a more holistic picture. So we want to talk to them about what's important to them, their values, their family, their friends. What is their life like? What are things that they want to be doing that might be impacted now? And how do they want to spend their time? Well, how can we make that happen? We also provide a lot of emotional support. So a lot of my job at Sibley is really to talk to patients about what is really bothering them at the moment, right? Is it family stress? Is it fear that their illness is progressing? Is it just needing to vent some negative emotions, and just making sure that I'm there to help provide that support. I also do a lot of education, talking about what different things mean, coordinating with different care teams, making sure the patients and the families have information that they understand in easy to understand language. And we get spiritual care involved when people are interested. We work with all kinds of folks. And I also help a lot with decision making when that comes up. So what else we got? This is the fancy World Health Organization definition: prevention and relief of suffering. And these are kind of some of the things that palliative care can help with. So we definitely start by identifying what is important, right? What are your values? Is it that you want to live as much time as you possibly can, and you want to be able to go golfing if possible? Or you want to, some people's goal is just to not have pain. And some people's goal is to make it to their niece's wedding in X number of months, right? So it's how are we focusing our help on what they want and really value. You've got the expert symptom management. We help with goals of care, which is really kind of a fancy way of saying, what are we doing? What do you want to focus on? Treatment and relief of symptoms that have come from this, like pain from neuropathy with chemotherapy, or side effects of treatment, or maybe a cancer is causing an obstruction, and so you're dealing with nausea, vomiting, and all of these things. So how can we help with that? The physicians on our team are really expert in that field. The goals of care, education, I've talked about a little bit. Oftentimes that looks like, here's what's going on, and here's what the team expects is going to happen from here on out. So asking people, how much information do you really want to know before we just say anything, right? We want to make sure we're respectful of people's different needs and wants with regard to information sharing about their illness. And so we'll talk about what is the difference between hospice and palliative care? What different kinds of alternative medicines are there? Can we get some kind of integrative care? Some people are really interested in acupuncture, and so we'll give them, resources for that in the community. We do a lot of care coordination with other providers, the emotional support. Advanced care planning refers to sort of making an advanced directive most of the time. So we make sure that if someone has a very serious illness and it could result in end of life at some point, that they have assigned someone for medical power of attorney, not durable, but medical power of attorney, to help make decisions for them if they cannot speak for themselves at some point in the future. And there's also a living will component. So you can do one or both. The living will often talk about really end of life kind of choices. It's how you want to live, but also what is not okay with you. So those usually have things about if you're in a terminal condition, do you want to be on a ventilator? Do you want to have CPR? Do you want artificial nutrition and hydration? Things like that. So we can help have those conversations. They're really hard to have sometimes with family, for an individual to have with their family. But it's so important to really get that out in the open so that there doesn't come a time in the future where hopefully it won't happen, but somebody is not able to speak and the family is really struggling. Well, what are we doing? Do we keep trying? Do we, if his heart was to stop, do we come in and do CPR? Do we have him on a ventilator? Would he want that? They don't know. So the advance directive sort of gives them a roadmap. We do a lot of family and caregiver support, again, spiritual support. And of course, not everybody receiving palliative care is going to become a survivor in their cancer journey, right? We hope that for everyone, but the reality is that sometimes that's just not the way it's going. So we do help families with bereavement, both before and after a death. So who provides palliative care? As we've alluded to, we operate in a specialized interdisciplinary team. So here at Sibley, we actually are growing very quickly. So right now we have an inpatient service, which is made up of 2 physicians, a nurse practitioner, a nurse, 2 clinical social workers, and we have chaplains that are very involved with our team. We also collaborate with the speech therapists and the occupational and physical therapists, nutrition, all of it. We newly have an outpatient clinic that's expanded. So now we have a physician and a nurse that see patients in the outpatient setting. So that is certainly an option. Family, we also consider members of our care teams. So, we can't overstate how stressful living with a critical illness is, and then being a caregiver or a loved one of someone with a critical illness. So we want to have that collaboration if the patients are okay with it, with how has the patient been doing at home? What is going on? How can we help? So we will very often have these lengthy family meetings that can involve the patient or not, their choice. And it's really to talk about, here's what we're seeing and here's what we're thinking, and what do you please give us your input, right? Thank you for letting us learn more about your loved one, and trying to get some of that background. We are a very patient-focused team. So everything that we do is really driven by what is important to that person. So we're not looking at a patient as a disease or an organ system or a body in a hospital bed or in the clinic. We want to really understand how someone has been living and how they want to live. So, we will ask about your history and what you enjoy doing and what gives your life meaning, who is involved with you and your care, and what have you done with your life? Like, we want to know you as a person. We also do all of these other things, navigating complex healthcare systems, but to us, dignity and the value of each individual is really important. So often you'll hear us ask, what do I need to know about you to give you the best care possible? Sometimes that's a really hard question for people to answer. But it's something, it's food for thought, right? But this is what I need. In general, palliative care aims to improve quality of life. I've said that 25 times, I apologize, and lower symptom burden. So we really do have, in the hospital especially, more time than most other providers. So it is not unusual for us to spend 1 or 2 hours with the patient and family on a given day. And then we can sort of circle back with the primary doctor or whoever else we have to interact with, case management, to really, kind of go over the outcome of these meetings. And everyone on our teams and in palliative care in general is pretty, there's specific training that people have, and you also kind of have to have like the right touch. These are very sensitive issues, and so we want to make sure that everyone that works on a palliative care team is really sensitive and able to connect with people pretty easily. I did want to show you one more tiny video. This is about a patient who has multiple myeloma and just how she has used palliative care to sort of re-enter life.
I saved
And we don't need
$700
the
with
ad,
Liberty
I'm
Mutual.
sorry. Please soon
Crazy what you
faster.
can get with those savings.
Oh my gosh. I am so sorry.
tongue? Mucinex
Didn't happen before. There we go. Okay.
Neuropathy it's a type of nerve damage. It affected my feet, my hands, and that's how I make my money. So I've been out of work for more than a year and a half.
I met Debbie when she came into the hospital with an acute pain crisis. She was really going through a lot in terms of just living with this new diagnosis, and then to be suffering from symptoms sort of related to the treatments so that she can live with the diagnosis.
With me being in the pain, I just shut myself out and just stayed in my room. The most they saw of me was to come out and get something to eat and go to the bathroom.
She was really crippled by this neuropathy. And you see, she does hair, and that was one of the things that came out when we were in the hospital. You know, sort of what bothers you the most about this pain.
They talk to one another, and they come and they talk to me with each other. Not, you know, they're talking just in a conference among themselves, but they include me in that conference that they're having with one another in terms of the medication I'm on, how I'm treating, how's the medication treating me, how I'm sleeping, how is my quality of life.
I mean, she's such a beautiful person and so lovely and social, and you can imagine for her not to be in that world, it really robs her not just of, you know, financial security, but her identity. And I think it's powerful to think that if you can give her some of that back by controlling her pain, you're really allowing the miracle of her treatment for her myeloma to fully realize itself.
I would not be back sitting in this chair right now if it wasn't for the program. I would be lost without them right now, lost.
She's a perfect example of how palliative care can help.
I feel I'm in the driver's seat because they're really concerned with how I'm feeling.
Okay, back to the PowerPoint. Okay, so you can see that this is a vivacious, engaged person who was really, really struggling. And she was able to have her symptoms managed so that she can kind of re-engage with her life. So she's not somebody who was worrying about not having more treatment options, although we see many, many people in that sort of phase of their illness. But she's somebody that really could benefit from the symptom management part of palliative care so that she could keep receiving her treatment and, you know, get back into life. So here, just a little chart of the differences, sort of background information. She was, before getting palliative care, she was having crippling pain from the chemo side effects. She was depressed. Her functional status was going down. She couldn't do the things she wanted. She was stuck at home, so she wasn't seeing friends and family as much. She couldn't work, so there was loss of income. And really all of this kind of results in suffering, sort of not just physically, but emotionally and spiritually, and with all that she is. Her family was distressed because they were watching her struggle and also having to pick up the extra pieces that she was no longer able to do. She had several calls to 911 and would come into the hospital for pain crises, which, you know, again, is just disruptive to life. Once she got engaged with the palliative care team, she received that expert management of her symptoms. She developed an ongoing relationship with the team. They gave her the support that she requested and could benefit from. And as a result, she was able to go back to work, and she was able to engage with her family and go back to social outings and just sort of, again, reclaim her identity. And she was able to stay out of the hospital, which is a good goal also. Even, yeah, if the goal is just to stay out of the hospital, we can work with that. Palliative care in general has a number of sort of pieces that we look at. So when we talk about palliative care kind of being a holistic way of looking, this is what we're talking about. So the structure and processes of care, it's sort of access points. How are you getting your care? Who's providing your cancer care? Who helps you? And also that advanced care planning piece. So the advanced directives and how can we help with that structural stuff. The physical aspects, of course, psychological aspects. Depression and anxiety are really, really common among palliative care patients. And it doesn't have to just be, right? We can work with you. We can help put you in touch with the right providers. If you're here in the hospital, we can do sort of brief counseling with you and start medications or whatever it is, because your mental health is very critical, obviously, to quality of life and to the care you're going to get for your illness. Social aspects of care. So again, that's your caregivers, your family, your friends, your church, your work folks, all of that we want to sort of respect and understand. Spiritual aspects of care. Spirituality is so important. It doesn't just refer to religious beliefs. So we want to understand if somebody is very involved in specific religion or with a certain faith organization, a church, a synagogue, a mosque, or whatever. And if not, that's fine. A lot of people say, yes, I'm a spiritual person, but I find that in my work with the homeless, or I find my spirituality in nature, in my art. It's just something I have in me, the knowledge of the universe. So it's different things to different people. And we're just here for any of that. Cultural aspects of care. Of course, people that come from different cultural backgrounds, different countries, different ethnic groups, oftentimes have different beliefs or ways that they've had stuff treated in the past, or just a whole host of issues that we want to understand and respect, so that we're not, trying to suggest one thing that is really in contrast to what their culture would otherwise say. If someone is very much heading towards end of life in our hospital, in the ICU, for instance, and the medical team is barking at them like we shouldn't put her on a machine, to the family, we shouldn't do dialysis, we shouldn't whatever, but the cultural and religious background of that patient and family is we do everything no matter what. So it's really understanding that and relaying it to the rest of the team. We do a lot of care of the imminently dying in the hospital setting. Like I said before, hopefully we're getting everyone out of the hospital, but this does happen, of course. I think my next slide's about that, and also the ethical and legal aspects of care. So when we're here, we talk a lot about hospice, and hospice is kind of an endpoint of palliative care. So if we're thinking about palliative as being an umbrella, and you can get palliative care anytime you have a serious illness, from the day of diagnosis all through treatment, stopping treatment, back in treatment, all of it. And then when there's no more treatment to be had, or you've decided to focus just on your comfort and quality of life, and there's maybe 6 months or so left or less, hospice is a very specialized form of palliative care for end of life. And we'll talk about that more a little later. But we do work a lot on facilitating hospice transfers for patients. Sometimes people die here. It's a hospital. So we provide a lot of education about what the dying process is and what it looks like and what families are seeing in the rooms. It's very variable, person to person. How much do you want to know, again, about what you're seeing? You know, some people really want a little booklet that explains at one, you know, when someone has maybe a week left, when they have a couple hours left, when they have, you know, when it's really close, do they want to know what they're seeing? And some people don't, and that's okay. So we're just there to help with that. As far as ethical and legal aspects of care, we often are asked to help with identifying a healthcare proxy for someone. This does not have to be palliative care, but in cases where a patient can't talk for themselves and there is no advance directive, which is why that is so important, we have to figure out who is the legal next of kin. Who can we go to help make decisions for this person? And sometimes it's not always clear. Or what else? Professional boundaries, knowledge of organizational policies, and just sort of make sure that, what have I done? Went backwards. There we go. Oh my goodness. So sorry. Okay. We're solid. And we also help communicate prognosis. A lot of times people want to know, how much time do you think I'm looking at? I need to know that to help me make decisions about whatever it is I want to keep doing with my life, or if time is very short, I want to know that so I can get out of the hospital. It's important for me to be at home. I want to finish this, that, and the other. I have projects I want to work on. Can you help me work on some of these projects? And so we often are the ones to relay that information. So this graphic I like, it's sort of a Venn diagram of palliative care versus hospice care. So in common in the middle here, you can see that certainly first and foremost is both palliative and hospice are focused on comfort. We want to reduce stress, offer complex symptom relief, and really focus on psychosocial aspects of care as well as the physical. The difference is off to the sides. There's a payer difference. So hospice is covered by Medicare and Medicaid and by private insurance. Palliative care as an outpatient is often paid by private insurance, sometimes by Medicare, and at times insurance doesn't cover it. Somebody's plan may not have that benefit. And so it can be a self-pay situation in the outpatient setting. Again, palliative care can be provided at any stage during a disease. And with hospice, we're looking at a prognosis of 6 months or less. And we've sort of accepted that time is short and that any more treatment is either not being offered or we've decided against it. The risks outweigh the benefits and it's making me miserable and I'm done. That's when hospice could come in. Whereas at palliative care, you can continue, you know, that is, we're supporting you through whatever treatments you're getting. Most of the time, palliative services are provided in the hospital, although we do have outpatient setting, right? We have our new little clinic and we have, it's not really, we have our clinic and we have a few agencies in the community that can also provide palliative care. Oftentimes they can see you at home or virtually, in addition to having clinics. And hospice is generally provided wherever a patient calls home. So that can be their own home, a family member or friend's house, place, apartment, whatever, a nursing home, an assisted living facility, wherever they generally live, hospice will go to them. This is a little, I'm not going to obviously read all this, but this is a great resource for more information. Getpalliativecare.org has a tremendous amount of education and resources if you want a refresher on anything that we talk about tonight. This is a nice little fact sheet. And this is sort of the question, right? Is is palliative care something that I should be thinking about? Got a little quiz, which is from getpalliativecare.org. So the questions to really ask, do you have one or more serious illnesses? We're talking about cancer tonight, so cancer, of course, qualifies. We see a lot of patients with heart failure and dementia and neurologic disorders also eligible. Do you have any symptoms that are making it hard to be active? Are they impacting your quality of life? Anxiety, depression, lack of appetite, fatigue, pain. Have you experienced any difficult side effects from treatment? Are you having trouble eating, for instance? Are you going back and forth to the hospital a whole bunch? Do you need help with certain things? Do you want to understand better what to expect, what your trajectory might look like, what kind of resources are out there, getting support, making medical decisions, and understanding pros and cons of different interventions and treatments? And finally, do you need or want help coping with the stress of this illness, with emotional support, spiritual support, and talking to your support system about what's happening and what's important to you? So if you answer yes to any of these questions, it might be something you want to consider. And the way to access palliative care, through Sibley anyway, is to speak with your oncologist or your oncology social worker, and they can make a referral. You can also call the palliative care clinic. I don't have the number on me, but we'll get it to you afterwards if you want. And talk to our intake nurse, and they can help you set up also. These are a few great resources for patients and families. Caring Connections has a lot of stuff about not just palliative and hospice care, but also has advanced directive forms that you can print and fill if that's of interest. And the Conversation Project is dedicated to really having those difficult talks with your loved ones. How do I start a conversation? Is there a movie we can be watching together and the topic just kind of comes up, and then I can say, hey, by the way. So it's got a lot of that helpful stuff. And those are my references for this program. And that's about it. I don't know if anyone has any questions or comments. You can put them in the chat.
Yeah, thanks so much, Rachel. One thing I wanted to clarify is if you are not a patient at Sibley, do you have access to palliative care, outpatient or inpatient?
Excellent question. Sorry for that. Yes. So at this time anyway, the palliative clinic is only seeing patients of Sibley. So we're only seeing actually oncology patients in the outpatient setting that see a Sibley provider.
Thank you. All right, so one question. How do you include a patient's perspective when they have advanced dementia and may be out of touch with their prior wishes and their own current experiences? Saying, I hate this, treatment or being in the hospital or being in skilled nursing / rehab, I hate this. One day I'm saying I want to live, and the next day I'm saying I don't.
Wow, that's a really difficult situation. How do we, is it how do I can't see it? We have, how do I take their perspective into consideration, knowing that it's kind of waxing and waning and not, okay. Often it's hard. That's really hard. So we talk to whoever's involved with that person. So family, friends, whoever's the caregiver, and try to understand what that person wanted historically. And, you know, in the absence of an advance directive, we're all sort of guessing unless there was a conversation. So the patient, unfortunately, once dementia becomes progressed enough, they're not always reliable, right? So you're saying, I don't want to go home. I don't want to go to rehab. Well, what is really, somebody else has to make that decision now, because that person doesn't have the capacity to really understand what is happening in their life. So for somebody that's got a confirmed diagnosis, and you know, we can check to see if they have capacity at any given moment to make decisions for themselves. but we really rely on others to help us with that.
Thank you. Got another one about how great the presentation was and that they
Very
did
kind.
not know about palliative care until now.
Wonderful. Well, that was the whole point, right? So that's great. Thank you. Yes.
Okay, how do you check to see if a person has capacity? For example, dementia.
Okay. I sense a theme. It's generally, there's some big formula with like 4 C's, and I can't remember what it all stands for. But you want to make sure that somebody can understand why they're in the hospital, why are they in the condition that they're in, what are their treatment options, and what are the risks and benefits of those treatment options, or decisions to be made. What are the pros and cons? If somebody cannot regurgitate that information to you after you've sat and talked with them about it, or just sort of lack an understanding of their condition and the options, then oftentimes that person is found to not have capacity. You know, and that's in the case where it's not maybe obvious, right? So that's somebody who's still talking and engaging and interactive. We, of course, have incapacitated patients who cannot speak, they're unconscious, they're had a stroke and have garbled speech, whatever it is. There's a number of ways, but often psychiatry will come and take a check also.
And just to add to that, I believe it has to be 2 attending physicians have to be in agreement.
Absolutely.
And then somebody asked if you have any references or anything for how they can find more information about lack of capacity.
Oh my goodness. That might have to be, and I'll get back to you on it. Let me think. Janie, do you know off the top of your head?
Most of the time I would say it's going to be defaulting to the primary care team, whether that's the oncologist or the hospitalist, whomever is working with the patient who capacity is in question.
Right. Yeah. You can sort of, I mean, I hate to say it, Dr. Google, you can sort of look up like criteria for determining capacity in a patient with dementia. And that would sort of provide a guide. Yeah.
Next question is, what qualifies as an attending physician?
An attending physician is the person that is in charge of your care at the moment. So outside the hospital, it's usually a primary care provider or your oncologist. In the hospital, your attending provider is the hospital doctor who's kind of guiding care, doing the day-to-day care, and is consulting other places like palliative care or nutrition or what have you. So it's the person who's really kind of like the quarterback of the game, calling the shots.
So for example, if you're admitted to the hospital, it might be the hospitalist who sees everybody on that floor, everybody with this diagnosis, and it could be the head psychiatrist, or it could be the palliative care doctor. It needs to be 2 doctors who would certify if capacity is in question.
I hope that helps. That sounds like a tough situation.
Well, we do have about 10 minutes left. I know that there was some questions trickling in. We
Sure.
answered most of them. So if anybody has any more questions, feel free to put them in the chat or in the Q&A. And if not, we can wrap up a little early.
That's rare for me. I usually talk endlessly, so.
I'm wondering, for people who live in, if there's any agencies in the community that maybe in like Montgomery or PG County, some of the places around Sibley that we have a lot of patients, like what agencies, if they weren't going to get treated at Sibley for palliative care?
Sure. There are a few. there is one, and I don't want people to get freaked out, but often the palliative care agencies are part of a hospice agency. So Montgomery Hospice, for instance, has a palliative arm called Palliative Medicine Consultants, and they serve Montgomery County and Prince George's County. They're very great. They're nice to work with. There's something called Empatia and Ennoble Care. What else? Accent Care, no, Affinity. Affinity has a small program now. There's a number of them. It's, again, most of the time, palliative care is really focused on inpatient. So it's a building specialty in the outpatient setting. So it's sort of sporadic. When I started here, there was like one agency that provided it in the community, and now there's like 3 or 4. So hopefully we'll get more going. Yeah.
Great. Getting a lot of thank yous and
Oh, you're
great
welcome.
presentation, helpful, important information.
My pleasure.
Somebody asked, how is Jessa?
How is Jessa as a hospice agency? I'm not supposed to give feedback on anything, but I know that they are excellent, and the only drawback would be that they tend to not be able to handle very complex cases. So if someone needs a pain pump, or has any kind of tube, really, they may not be able to handle that. So, but they're lovely and would tell you up front if that was something that they could or could not handle, and send you to a different agency. One thing that I will mention is that there's a difference between home hospice and inpatient hospice. And so sometimes people will choose an agency based on availability of the inpatient hospice, which really is driven by Medicare criteria. There are very specific guidelines about who is eligible for an inpatient hospice stay. And that's not hospital, that is a hospice facility. So there's one here on campus. It's run by Capital Caring. It's on the 5th floor of Building C. It's a small unit. There's one in Montgomery County run by Montgomery Hospice. It's called Casey House. That's actually a freestanding building. And to qualify for inpatient care, it's kind of a mixed curse and blessing, because you have to really have symptoms that cannot be managed elsewhere. So in order to get that 24-hour intensive care, you kind of have to be in a really bad spot. So, but sometimes people will take that into consideration if they're deciding on an agency. Yeah. That it?
I think that's it. Thank you so much,
Okay.
Rachel. It's a great
You're so
conversation.
welcome.
Really great and helpful information. So for everybody who attended, you will get the recording, and then we will get the slides from Rachel and be able to send those out to everybody as well. And if you have any questions, feel free to reach out to either myself or Kara. And thanks everyone for coming.
Thank you so much. Nice to be here. I wish I could see your faces.
Bye everyone.
Bye.